My name is Tapan Kadia. I am Associate Professor in the Department of Leukemia at MD Anderson Cancer Center. In this module, we will review our current knowledge and experience with maintenance therapy in acute myeloid leukemia. Maintenance therapy in AML is not currently standard. However, there have been several attempts to try and institute maintenance to extend remission rates. CR rates with frontline chemotherapy with newer therapies are high, but relapse is frequent. Post-consolidation strategies for high-risk patients who are not candidates for allogeneic stem cell transplant are limited. Many studies have been done previously using chemotherapy-based maintenance strategies, and they have been ineffective in improving overall survival. Novel approaches to potentiate immune surveillance or induce apoptotic pathways in a low disease burden state may be effective. When we talk about low disease burden, we talk about minimal residual disease, or MRD, and this can be quantified in several different ways. For years, we've been doing this with chromosomes in patients who had abnormal cytogenetics. Flow cytometry is more sensitive, able to pick up an aberrant immunophenotype in 1 in 10,000 cells. And the next generation deep sequencing may allow even better sensitivity. We also know that the presence or persistence of minimal residual disease, in this case by flow cytometry, at the end of 1 or 2 courses of therapy in acute myeloid leukemia predicts for higher incidence of relapse and inferior overall survival. If there was a way to eradicate this minimal residual disease, that can help potentially improve long-term remission duration and then overall survival. Over the next few slides, I'll go over some of the historical studies that have been done to evaluate the use of maintenance therapy for long-term in patients who have achieved a remission with induction and consolidation chemotherapy. The first slide here is an ECOG trial looking at maintenance therapy with thioguanine at a dose of 40 milligrams per meter squared on days 1 through 4, and then cytarabine on the 5th day, monthly for 2 years after achieving maintenance. 25 patients received maintenance, 26 did not, and what they showed is that although there was an improvement in CR duration and relapse-free survival, there was no improvement in overall survival. A CALGB study randomized 151 patients to either maintenance for 36 months or just a consolidation strategy of 8 months. And what they found here is that there was no benefit in relapse-free survival or overall survival in patients who received maintenance. In fact, as you can see in the curve in the right lower hand corner, there was actually an inferior survival in patients who received 36 months of post-remission therapy, suggesting there was no benefit for maintenance therapy. In this case, the chemotherapy used was similar to what was used in induction and consolidation. Next, this is Bob Bloomberg looking at low-dose cytarabine maintenance, again randomizing patients between low-dose cytarabine or placebo for 8 cycles after receiving consolidation therapy. And again, there was an improvement in disease-free survival, but no significant improvement in overall survival. And so a German study group has done several studies looking at a high-intensity consolidation versus a maintenance strategy for 3 years. And what they showed, once again, the pattern continues where there's an improvement in relapse-free survival, particularly in those with poor risk karyotype or high-risk disease, but no significant improvement in overall survival. This is a similar study, but in this case looking at transplant, an autologous transplant versus maintenance therapy, and there was no difference either in relapse-free survival or overall survival, suggesting that perhaps the maintenance was just as good as autologous stem cell transplant in patients with acute myeloid leukemia. These are some of the older studies. Newer generation studies have looked at hypomethylating agents such as decitabine. This is another more recent CALGB study looking at 134 patients, a single-arm study looking at decitabine in the post-remission setting. And here, the 1 in 3 year disease-free survival rates were 79 and 54%, but when they compared to the historical control, there was no difference, and therefore suggested there was no improvement and benefit. This is an interesting study, moving away from just chemotherapy, but using histamine dichloride and interleukin-2, trying to activate the immune system to mimic immune surveillance that you may see potentially post-transplant. And here, what you see is that there was indeed an improvement in leukemia-free survival in patients who received 10 3-week cycles of IL-2 with histamine dichloride. And this was probably the closest study in improving overall survival, but again, there was no survival benefit. Lenalidomide, this is some of our own work looking at oral lenalidomide maintenance. The treatment is listed here at 10 milligrams daily, given continuously for 24 cycles or 2 years. And what we found here, very early follow-up, just 19 months, is that there seems to be a flattening of the curve in patients with high-risk disease after induction and consolidation who are unable to receive allogeneic stem cell transplant. You can see here that the 12-month CR duration was about 69 months with an overall survival of 92% at 12 months. Again, this is early and further follow-up awaits. Similarly, we used immune checkpoint inhibitor-based maintenance therapy with Nivolumab, where we give the Nivolumab every 2 weeks for 6 months and then every month for 6 months, followed by every 3 months for a total of 2 years of treatment. And here, once again, with a median follow-up of about 19 months, we can see that the 12-month CR duration is around 45 to 50%, against something similar to what you would expect in patients with high-risk disease in first complete remission. And here's the overall survival, where there seems to be some potential survival advantage in these patients, but these studies are early and ongoing. A randomized study done by the Hovan group was recently presented at the ASH meeting, and what they found is that in older patients who had received 2 courses of intensive chemotherapy, they were randomized to receiving either azacitidine for 12 cycles versus no further therapy. And indeed, there was a significant improvement in disease-free survival of 63% with AZA versus 39% with the placebo or no treatment, the observation arm. And clearly, this is a trial looking at basically treatment versus no treatment after 2 cycles of therapy. So the results are difficult to apply clinically. What about decitabine versus conventional care? This is a study published by our group looking at more intensive chemotherapy versus decitabine as maintenance in patients who had achieved remission, and we found no difference in overall survival. But what we did show again is that the persistence or presence of minimal residual disease prior to starting maintenance therapy did predict significantly for overall survival, event-free survival, and relapse probability. And finally, the most recent study, a post-transplant maintenance strategy looking at azacitidine for patients who have MRD-positive disease in an effort to eradicate this. We find that 28% of patients who are MRD-positive went with treatment with azacitidine. Among the people who had azacitidine, 58% remained in remission at 6 months, and 40% had declined in their minimal residual disease as quantitated by flow cytometry. So this study is still ongoing. Again, it's a single-arm study, but we should certainly see more results after this. And so finally, in summary, CR rates in AML continue to improve with conventional therapy and new advances in treatment such as venetoclax and monoclonal antibodies. Relapse disease, after achieving remission, it remains an important challenge, and persistence of minimal residual disease after morphologic CR by most modalities predicts for higher rates of relapse and inferior overall survival. So if there was a way to eradicate this residual disease and prevent relapse in a maintenance setting, this remains an important priority, and further research should be done in this area.